talking about the CTO procedures cath lab setup, how to set up a cath lab for a CTO intervention. He's a senior interventional cardiologist from Apollo Hospital, Hyderabad, Telangana.
So good afternoon, chairpersons, and at the outset I am thankful to Dr. Goyal for giving this opportunity. So for the beginners and junior colleagues, how we can start a CTO program, both cath lab setup and hardware. Of course, some of the revision slides are there, which I can skip off. And this is my agenda. So myths and facts of CTO, and there are 4 important factors which ultimately very important in developing the CTO program, that is operator factors, cath lab factors, administration factors, and referring physicians and patient factors. And these are some of the myths, especially CTOs are common. CTOs are one of the most common reasons for referring patient to CABG. CTOs are not benign. CTOs adversely affect our patient's quality of life and longevity. Only 10% are attempted percutaneously. Historically, the success rates have been disappointing low. CTO PCI is technically challenging. CTO PCI can be associated with complications. Patients with CTOs are often undertreated. These are some of the myths and facts among the Interventional Cardiology Forum. And for developing the operator skills, these are most important. On-site proctorship for recognized world experts, especially our Japanese senior colleagues, are most important. And unique settings of 2 operators scrubbing in each case is most mandatory. And developing the relationship with industry to acquire novel technologies not widely available. So should associate with CTO masters like Japanese for developing a CTO program, which we started in 2006 as a CACTO program. And most important, in developing weekly CTO team meetings to prospectively discuss the cases step by step and decide on appropriateness of proceeding with PCI, and implementation of review of past cases, whether they are successful or the failed, for adherence to quality initiative. And there should be some CTO PCI days where dedicatedly the lab should be filled with the CTOs, especially maximum 3 cases per day. And education of the junior colleagues as well as the physicians and staff is most mandatory, and we should create a database so that we can analyze our skills and improving the skills in failed cases, and discussing the success reasons also. And regarding the cath labs, especially some of the cath labs are associated with less 50% less radiation, especially Philips, Claret, and Shumarju. These should be owned because of radiation safety is also important. And the radiation exposure procedure guidelines we have to follow, especially close collaboration with radiation safety experts, and wearing the radiation badges and reviewing the radiation dose for the interventional cardiologist. And inclusion of techniques to minimize the radiation dose, like majority of the case we should do under fluoro only, and minimizing the cine loops. And third important, involving the rad pads, especially some of the radiation sheets nowadays available, we have to use especially for CTOs to minimize the radiation to the operator. And about the procedure, if the lesion is not set 8 grays, and about the procedure if radiation dose reaches the 12 gray. And most important, the contrast exposure, this is also you have to take care, especially by adopting the techniques for minimizing the contrast usage, including dilution of the dye, that is 80-20%, and use of wires for as a markers, and intravascular ultrasound. Especially our Japanese colleagues, they invented these techniques of retrograde doing the angioplasty CTO with a very 9 ml of the contrast. Like this, we have to adopt those techniques to minimize the contrast. And we should maintain the standard cath lab protocols. That means every 30 minutes we have to monitor the ACT. For antegrade approach especially should be maintained between 250 to 300, and for retrograde it should be more than 350. And contrast volume also should be assessed, especially the maximum contrast, if it reaches 300 ml, you should abort the procedure, or more than 600 also you should minimize this one. And radiation dose, as I discussed, 8 grays, if it reaches, you have to abort the procedure. And we should identify the technicians, we should train the technicians for especially they should come for the CTOs, so that we can have discussed with the technicians regarding the where we have gone wrong or where we have deviated from the procedure. And we should identify the nurses especially for CTO techniques, so that they can give suggestions in between. and CTO days, as especially weekly 2 CTO days for dedicatedly the lab should be dedicated CTO days, and CTO lab should be exclusively there, like EPS cath lab, like CTO cath lab should be there. And as a CAT2 we started and ultimately evolved into IJCTO, and since 2006 and till March 2000 we almost performed 781 cases of CTOs with success rate of 89.9%. And apart from these, administrative factors also play significant role, especially economically with a disincentive or attractive. In which hospital stay might CTO reduction be economically favorable, you have to use. Especially this most important, we have to discuss with administrator regarding the CTO packages. Apart from the routine package, any extra package for the material, and we have to discuss, we have to sit. And regarding stent utilization, of course in India it was now came down, and hospital stay duration should be calculated in the package. And cath lab utilization time, especially fluoro time, also should calculate and discuss with the patients and administrators. And we have to convince the administrators so that they should cooperate regarding the economic outcomes of the CTOs, so that their factors also play in building the CTO programs. And another part important is referring physicians, especially we have to remove some of the stigma of the referring physician that CTOs are unsuccessful and they are unnecessary. So by sharing our success to the referring physicians, we can improve the CTO programs, and conducting CME programs as well as the workshops, especially live cases. We have to call the referring physicians so that they should know that yes, by advanced techniques, by associating with the Japanese colleagues, we can improvise the success rate. We should inculcate that idea in that, so that more number of CTO cases we can perform. And of course, by CTO clubs, especially like IJCTO we are conducting, this also improves the CTO programs. And retraining our junior colleagues and sharing the success and educating the patients via YouTube, Facebook and other media, we can also increase the number of the caseload, so that we can build up CTO program more successfully. And apart from the operators should have an idea on the CTO cart, which contains a toolbox of CTO PCI, as already is a revision. Dedicated CTO sheaths, guiding catheters, wires, microcatheters, snares, especially for managing the complications and management, as well as use of the utility of the imaging for CTO PCA. Of course, already these are repeated, just I will go through, and these are the guiding catheters. And of course, guide extension catheters are most important in the toolbox for improving the success and improving the operator skills. And all the CTO wires should be possessed in the lab, and microcatheters, Dr. Baiju already discussed regarding this one, and these are the repetition. And operator should have the knowledge over this CTO cart regarding the wires, microcatheters and hardware. And this is important, especially the snares. We should have complication management hardware also should be there, cover stents, coils, embolization particles and fat embolization. And imaging is mandatory, especially when you are building above the CTO programs for these purposes, for successful outcomes. And with this, I concluding, building up of successful PCI CTO program indicates operator skills. We should have knowledge regarding the lab with the minimal radiation, and following the radiation safety as well as contrast safety, as well as the knowledge on the hardware. And it should be equipped cath lab should be there, and dedicated CTO technicians, CTO days, and CTO nurses, that is skilled nurses, should be trained. And administration support regarding the economics should be discussed with separate packages, and awareness among the referring physicians and patients by means of media and live cases and workshops. With this, we can build up a successful CTO program. Thank you.
I think it was mainly an administrative talk.
Yes.
We should not focus on some cath lab will be much better than the other cath lab. I think every cath lab has radiation safety measures nowadays. We have to be careful about safety measures from our side. I think the economics is not the problem. The central government health scheme and all is definitely not differentiating a CTO intervention from a normal PCI program in the country. That is actually the major hurdle we have to face, and we have to, our leaders should go to the government and focus on the complex CTO program, and the basic CTO interventions. Basic angioplasty are totally two different pieces of work That should be focused to the government. Then only we can improve the CTO programs. I think it was a wonderful talk. One or two questions can be from the audience because he was mainly giving an administrative talk.
Yes. 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 Yeah. No, you should have the knowledge and you should have a important standby because they are very deceptive because CTO means always successful won't be there. So whenever a need for imaging is there, you should be equipped in your lab imaging. Hmm. No, this yes. No, no. If in the middle of
No,
the case,
that is actually never recommended in anywhere. You
But-
can actually, if you have a ambiguous CTO, you have a success rate is very low. You
Yes.
can have an imaging association. Actually, imaging
Success
help
rate
can
is-
be taken, otherwise not required, and it is not mandatory.
success rate is high. That's all.
Definitely high. I think. Actually, sir, we have a wonderful talk by a CTO, when to do CTO, how to do CTO. There was in the first
Image.
session, which was actually over. It was a 12 minutes talk by Rajesh was done.
Next
I think we
session-
cannot go for the further discussion on that, and then we'll go to the next.
Can I just give one administrative comment? This side, the problem with CTO, my problem is, when a patient comes, he says, what is the estimate? I don't know how to give estimate of CTO.
You can make one
Okay.
comment and finish.
That's-
I think with this talk, we will be finishing the session totally, and
Thank
it was excellent speech by